Welcome to the first talk of the International OCD Foundation Hoarding Conference for 2021. My name is Randy Frost from Smith College.
And I'm Gail Steckety from Boston University. It's our pleasure to present to you today, Hoarding the Basics.
This session is meant to be an introduction to what we know about hoarding disorder. It will present background that will allow you to get the most out of the sessions today and tomorrow. We'll talk for about an hour and then answer questions. You can use the chat function to send them to us as we go through the presentation. We're going to cover three basic things today. First, what is hoarding disorder? We're going to talk about symptoms. We're going to talk about the diagnostic criteria, just basically what is hoarding and its ramifications. We're also going to talk a little bit about why do people hoard. We're going to present a cognitive behavioral model that is our best attempt at combining what we know about hoarding disorder that tells us something about its etiology or where it comes from or how it's maintained. And then finally, we're going to spend a little bit of time talking about cognitive behavior therapy for hoarding disorder. So those are the three things we're going to cover. And first, we're going to start with the diagnostic criteria for a hoarding disorder. There are three major inclusion criteria in the Diagnostic and Statistical Manual for Mental Disorders. The first of these, criterion A, is persistent difficulty discarding or parting with possessions regardless of their actual value. There are a couple of things that are important about the content of this diagnostic criteria. First of all, the difficulty has to be persistent. It's not something that's temporary. It's not something that really comes and goes. It's a persistent difficulty. Secondly, the difficulty is not just with discarding things, but parting with them in any fashion, either selling them, giving them away, or even loaning them. And finally, the difficulty discarding is for objects that are of all values, regardless of their actual value. And this is really to combat what was a myth that hoarding disorder really was the difficulty getting rid of worthless or worn out things. It's really everything. The value of the object doesn't matter so much. The second criteria, B, is that this disorder is due to the perceived need to save the items and distress associated with discarding or letting go of them. And the third criteria is really a result of these first two. Criteria C is the accumulation of possessions that clutter active living areas of the home and substantially compromise their intended use. The focus here is on active living areas of the home, and the focus is also on the compromising of the utility or the use of that space. Now there's a caveat here. If the living areas are uncluttered and it's only because of the intervention of third parties, a person can still meet this criteria for hoarding disorder. The fourth inclusion criteria is criteria D, that it causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, including the ability to maintain a safe environment for oneself and others. Now, there are two exclusion criteria here. That is, if these conditions exist, then we do not make the diagnosis of hoarding disorder. That is, if the difficulty is not attributable to another medical condition. If it is attributable to something like a brain injury or a cerebrovascular disease, we do see sometimes, then it would not be considered hoarding disorder. Secondly, if the disorder is not better accounted for by another DSM-5 disorder, mental disorder like obsessive compulsive disorder, major depression, psychotic disorder, dementia, or even autism spectrum disorder, where we sometimes see some of these behaviors. If these behaviors are really the foundation for the hoarding, then we do not give the diagnosis of hoarding disorder. Now, in addition to these criteria, there are diagnostic specifiers. So if someone is diagnosed with hoarding disorder, then the clinician will specify two things. First of all, is this behavior accompanied by excessive acquisition? We're going to talk a little bit more about acquisition in a few minutes, but this is the way in which the objects or items are accumulated, is that excessive? And we'll talk about some of the research on that in just a minute. The second diagnostic specifier is whether or not the individual has insight. Now, by insight here, what's meant in DSM-5 is whether or not the person recognizes the problematic nature of this behavior. And there are three different categories. So you indicate whether the person has good or fair insight, poor insight, or absent insight. We're going to talk about insight a little bit later on in the talk, but just as a precursor, we're not entirely sure what percentage of people with hoarding disorder displayed as absent insight. In research samples, we see a relatively small percentage of people who have absent insight. Most people have good or fair insight. But in community samples, where people aren't volunteering to be in research, but they're identified because of difficulties that show up with community agencies, then we see a much higher proportion that are judged by observers to have absent or limited insight. So one of the things we want to do now is walk through the home of someone with a moderate hoarding problem. This is a 50-something-year-old woman who lives in the home with 2 children. And this is her kitchen. I want you to notice a couple of things about the kitchen. First of all, most of the horizontal surfaces are covered except for a small corner of the table where she and her children eat their meals. Now, obviously, they can't eat at the same time, so there's a disruption in routine. It's hard for her to cook because there's no room to prepare meals and so forth, another disruption in routine. But one of the things I want to point out to you as we go through here is what we see here in the piles of things are some interesting features of hoarding. So what we see on top of the tabletop is a relatively random assortment of things. We see light bulbs, egg cartons, newspapers, ribbons, wrapping paper, and a few other things like that, a seemingly random assortment. In the back, we see some real impairment here where the stovetop is next to a pile of paper. So we have a heat source next to a fuel source, which is a source of concern for us. In this room, we see a different kind of stuff, but we still see kind of a random assortment. We've got some plates, a vase, some plastic containers, some with game parts in them, piles of books, and we even see the top of storage containers, which are not uncommon for people with hoarding disorder to collect the kinds of items necessary to start organizing, but yet those items end up in the pile themselves. This is the same room looked at from a slightly different angle. And the important thing here is, you see the nature of the things seems to be kind of a random assortment of things, not well organized, but they cover the front door of the house so that it makes it impossible to use that entrance or exit to get out. Now, this would be of great concern to a fire official, especially because of the fire danger associated with the kitchen. If you're here in the house, it would be difficult to get out. This is the individual's TV room, and you can see, again, a large pile of things, and with a small area at the corner of the couch where she sits. And she told me that she sat there for several hours every day trying to work through these things. And largely what happened is that she simply picked up items, recited why she kept them, and put them back in the pile, and basically churned the pile while she was working and unable to get rid of virtually anything in that pile. This is an upstairs hallway, and what we see here is much like the rest of the house, but inside each of these bags are gifts that she's purchased when she's been out shopping, thinking that she's going to give these gifts to someone. And it's sort of a common behavior for her to be out somewhere and see something and think that would make a great gift for someone. She buys it, maybe it's on sale, so forth. It ends up here, and it never leaves. So some of these bags are decades old. For about a third to a half of cases with hoarding, we see that the material spreads to the outside of the house. And this is really the marker that differentiates who gets identified by health department officials, elder service officials, and so forth. Yeah, outside of the home is a marker that often leads people to start asking questions about how well the person is able to take care of themselves. You can see here not only stuff being piled up, but there's some deterioration in the building itself, which is not uncommon in some cases. And then finally, we see that for people with this disorder, frequently any kind of container that they have available to them gets filled up. And this is the car of someone with hoarding disorder. You can tell that it would be difficult to even put this car on the road and drive. So that's another feature here. Now, for the most part, when we've done research on hoarding disorder, what we find is that there really aren't any subtypes of hoarding disorder except for one. And that is when the hoarding is of animals rather than objects, or in addition to objects. And there's not a lot of research on animal hoarding. It's a hard thing to study, but there is a group, the Hoarding of Animals Research Consortium, that's done some work in this area and has come up with a definition of what is animal hoarding. And it's characterized by these three features. First, the accumulation of large number of animals. And the exact number of animals is not specified, just a large number, because it's really the next two features that define this problem. The second feature is the failure to provide minimal standards of nutrition, sanitation, and veterinary care. And then finally, a failure to act on the deteriorating conditions of the animals and of the environment. Now, if we look more closely at animal hoarding behavior, it seems to fit the diagnostic criteria of hoarding disorder. So the diagnosis of hoarding disorder for people who hoard animals is probably appropriate. But it looks like this may be a slightly different feature, or have special features about it that are a little bit different than for people who hoard just objects. So if we're thinking about what we see here, that is, what is hoarding behavior, there are three different manifestations that lead to a cluttered house. And the first of these manifestations is acquisition. The items have to come into the house in some way. And the question is do they enter the house in a way that's different from people who don't suffer from hoarding disorder? Secondly, there has to be a decision to save the items. And is that saving behavior has to be intentional in some way. And so is it because they want to save the item, or is it because they have difficulty letting it go? Maybe they may not want to keep it, but they have difficulty letting it go. We do see a little bit of both of those things. And then the third feature associated with clutter is disorganization. I'm going to talk a little bit about each of these three. So acquisition, there are four types of acquisition that we've identified, and these apply not only to people with hoarding disorder, but to other folks. Buying behavior, the woman whose home we toured had great difficulty going to New York City, because if she went to New York City and she was on the street, she would see invariably a news kiosk. And she looked at the news kiosk and she would have the thought, look at all those newspapers and all those magazines. Somewhere in all of that, there's a piece of information that could change my life. How can I walk by without it? And for her, the only way she could handle that is to look cross the street, look the other way, and avoid any kind of a visual representation of that kiosk to keep that thought at bay. We'll talk a little bit in a second about the frequency of compulsive buying in hoarding disorder. We also see, it clearly is the main form of acquisition. Another major form is the acquisition of free things. So the woman whose home we toured had a special arrangement with the postmaster that any newspaper or magazine where the address was unreadable would be put in a box, put out in the foyer of the post office, and she would stop by on the weekend and pick it up. We do see some stealing in hoarding disorder, but it's really a very small percentage. It is higher than it is for the normal population, but not high enough to characterize more than 8 or 9% of people with hoarding disorder. And then finally, there's some passive acquisition in hoarding. That is, junk mail comes into the home without being invited, often gets saved as well. So these are the major forms. And when we look at the research here, what we see, if you look at this pie chart, 60%, this is a sample of people studied in 2013, about 60% report excessive acquisition problems. Another 28% say they don't have those currently, but they had them in the past. And an additional 4% say they don't have current excessive acquisition or past excessive acquisition, but yet they admit to us that they avoid going to some stores or some places because they fear they'll overbuy. And only 8% report no problems with acquisition. Now, interesting, the majority of people who say they don't acquire right now, but they did in the past, had stopped the acquiring by avoiding going to places where they acquire excessively. We know this is a very effective way of controlling acquisition. So acquisition, even though it's only a specifier for DSM, it is a major component in over 90% of hoarding cases. So that's an important thing to keep in mind. And what we see is the buying is the most frequent. And this is a different sample. Nearly 80% had excessive buying. Another 60% or 60% had excessive acquisition of free things, and about half of hoarding cases do both, to buy a lot and acquire things freely. Compulsive saving or difficulty discarding, the second manifestation. The first thing we talked a little bit about is subtypes of hoarding. Can we divide this up by people who save different types of things? Well, really not. The only real distinction is objects or animals. The types of items, most often people save clothes, newspapers, books, containers. If you look at the nature of things saved, they really are the same kinds of things saved as people who don't have hoarding disorder. It's just that the volume is much higher. By and large, these are not things that are worthless or worn out. So that was one of the myths, early myths about hoarding disorder, that it really involved things that were only worthless and worn out. But now we know that people who hoard save virtually everything, things that have value and maybe things that have less value, at least to other people. One of the things that determines whether this is an intentional saving or just difficulty discarding has to do with the nature of the attachments that we see here. And there are three types of attachments, and we'll talk a little bit more when we get to the model about these attachments in much more detail. But a sentimental attachment refers mainly to an emotional connection to an object. Instrumental attachments have to do with the utility of the object. Is it useful? Is it something I need to get by? And intrinsic attachments have to do with the aesthetic quality of the object. Sometimes we see people who save lots of things because they are aesthetically pleasing. Something about the physical structure, physical nature of the objects captures their attention. We had a woman who saved everything purple because she just loved the color purple. That's what this intrinsic motivation for hoarding is. And then the third manifestation is disorganization. So we see disorganization in the condition of the home, and you can tell by the clutter in the home is an index of disorganization. But also a lot of this feature has to do with the fact that there's a mixture of important and relatively unimportant things here. So you look here, much of this information, much of these newspaper articles and so forth have relatively little importance for the person. They clearly have some importance, but it varies widely. So somewhere in this pile is the title to her car. Somewhere in the pile is a letter from the insurance company about a car accident she had recently that she needs to find somehow. And so this pile is a mixture of things. And one of the things we see is that objects are organized a little bit differently for people with hoarding disorder. They have difficulty with categorization. And the organization is more visual and spatial. So if you ask her where this letter is from the insurance company, she may have an idea of where it's located in space in that pile. The other kind of disorganized feature has to do with behavior. And I've already described one of the behaviors, is churning behavior, turning things over is a form of disorganization. And the other feature that goes on here has to do with the fear of having things out of sight. I didn't show you her bedroom, but in her bedroom, there were clothes stacked from the top of the dresser all the way to the ceiling, but her dresser drawers were empty. And what she said is, if I put the clothes in the drawer, I won't be able to see them, and then I won't remember that I have them. So they'll be of no use to me. So there are these features that are important components of this sense of disorganization. Okay, so that's the nature of the symptoms. Let's talk a little bit more generally. Prevalence rates, there are now more than half a dozen studies on prevalence from around the world, mostly in Western countries, United States, Germany, the UK, Sweden, the Netherlands, some from other places like Italy and so forth, and a meta-analysis of prevalence rates among all the studies of prevalence suggests that it's a disorder that affects about 2.5% of the population. And so this is the best estimate we have of how often we see significant hoarding problems, or hoarding problems that would be serious enough to be diagnosable. Now, there are a few other features, associated features that are important. One of them has to do with comorbidity. How often do we see other mental disorders associated with hoarding disorder? And the answer is the most frequent of these is depression. And we see major depressive disorder in about half of the hoarding cases that we've studied. We also see some other anxiety disorders that are relatively frequent. GAD, or generalized anxiety disorder, a disorder characterized by worry. We see in about almost 30% of hoarding cases. Social anxiety disorder, SAD, social anxiety disorder, we see also in about 30% of cases. Attention deficit hyperactivity disorder is common. Again, almost 30% are diagnosable. Many more than that have some features of problems with attentional things. OCD is a little bit less. About 18% of people with hoarding disorder also have an OCD diagnosis. Now, this is a little bit difficult to separate because initially hoarding disorder was considered a feature of OCD. So sometimes the diagnosis, if the studies are old, conflates the two a little bit. One of the interesting things is that we see a relatively low frequency of post-traumatic stress disorder. And this finding is somewhat surprising given the fact that in some other research, we find that a large number of people with hoarding disorder have experienced some form of trauma. So in this particular study, what we found was about 50% of people with hoarding disorder had experienced a significant trauma, comparing them to people with OCD, where only about a quarter of them experienced some significant trauma. But yet the frequency of PTSD did not differ between these two groups of patients. So it suggests that there's something going on there, and that maybe, it's only a hypothesis, but maybe hoarding symptoms somehow buffer against the development of PTSD, or somehow buffer the PTSD symptoms. Again, that's speculative, we don't know. Now, we also see hoarding disorder. This sort of turns the research on its head a little bit, and instead of saying, what is the frequency of disorders, other disorders in people with hoarding, turn it around and say, okay, if we start with people who have anxiety disorder, what is the frequency of serious hoarding symptoms? So this is a study where we looked at people with different anxiety disorders, panic disorder, specific phobia, OCD, social anxiety, and generalized anxiety disorder, and then looked at the frequency with which they had serious hoarding problems. Now, these are people who came to an anxiety disorder clinic and did not on intake indicate any problems with hoarding. And what we see for OCD, about 10% of them had significant hoarding. For social anxiety, about 15%. And for generalized anxiety disorder, again, this disorder characterized by worry, we see over 25% of them had serious hoarding problems. So this is a significant issue in understanding how often or where we see hoarding cases, and where people come in for help and they don't report it. So it suggests that maybe some further screening might be helpful. Onset, hoarding behaviors begin relatively early. The average age across studies that have that have been done on the onset of hoarding suggested about 17 years old. And you can see this graph, this bar graph is from some of our data on onset. You can see between the years of 11 and 20 years old, that's when most of the cases get started. And when they get started, they're not always that extreme, and they seem to grow in severity with increasing age. So at younger years, below 10 years old or so, the prevalence rate of hoarding is low, about 2% or lower. But by the time you get to age 60 or so, the prevalence rate for moderate to severe hoarding is above 6%. And there's some kind of an inflection point at about age 35, something like that, where the symptoms seem to get serious more quickly. It seems to escalate in severity. We do see hoarding in children, although the prevalence rate is lower than it is for hoarding in adulthood. Even though hoarding symptoms begin in childhood, they really aren't very severe for a couple of decades. But when we do see hoarding in children, what we see is a lot of overlap with other disorders, particularly like attention deficit hyperactivity disorder, and some other disorders like that. Now, one of the complications with hoarding in children is that sometimes kids don't have control over how much they can acquire. They also don't have control over their living spaces in the same way that other people do. And so that complicates the thing but a little bit. But what we do see is from parents who have children with hoarding problems, it's the extreme emotional reactions to other people touching or moving their possessions. Now, kids with hoarding disorder have relatively limited insight. That is, they don't recognize what's going on. And they have an abnormal level of personification. Now, in some ways, this is characteristic of all people with hoarding disorder, the high level of anthropomorphizing objects. But here, this abnormal personification seems pretty extreme. For example, one of the cases that we've dealt with, a little boy with hoarding problems is in one summer afternoon, real hot day, his mother gave him some Kool-Aid. He walked outside, spilled the Kool-Aid on the driveway, and became upset because the Kool-Aid was being hurt by the heat in the driveway. And so you see that that's part of this sort of abnormal level of personification. All right, so now we're going to talk about hoarding in elders, but we're going to turn over to Gail to talk through it.
Hi, everyone. A reminder that you can put into the chat any questions that you might have, and we will try to be answering those as we go along. So with regard to hoarding, we do very commonly see it in older adults. And you can see here some of the research that we've done showing that it occurs in perhaps up to a quarter of nursing home settings or daycare settings or public housing settings where elders are primary tenants of those settings. We also see quite a lot of hoarding in chronic and age-related medical illnesses. We don't always know whether the medical illness is leading to some of the hoarding problems because people are not mobile, but it is certainly common in older adults who have such conditions. We also see significant impairment in the activities of daily living in older adults. And again, this may very well be connected to their medical situation. But the other possibility is that people who hoard are unable to do things, as you saw in the case that Randy described in her kitchen. There were many things that she could not do, such as preparing meals or even washing quickly afterward. So it's clear that the situation in the home is such that it impairs these activities. We are often concerned that senior adults will be relocated to housing that is not their preference because of the hoarding problem. So that remains an issue for a number of people whose homes are so cluttered that they really cannot continue to live in them. There is obviously a risk of homelessness, and I'll speak to that in a few minutes. And of social isolation, which is something that we always worry about among older adults. who are less mobile or less capable of getting around. And as Randy mentioned, there are problems among people with hoarding of social anxiety, and that could indeed contribute to some social isolation as they get older. So let's look now at the hazards of hoarding. And I'll walk through several of these. You can see from the left-hand column that there are multiple hazards associated with hoarding. And these are the things that especially concern family members and community members when they encounter serious hoarding problems. Poor sanitation is one of them. We did not see that in the home with moderate hoarding that was shown to you earlier, but this is a home that might be typical of someone with a very serious problem in which sanitation is quite an issue. In such cases, people are often, the community members are compelled to call for help with public authorities to deal with it. Another problem that develops is mobility. And here you see a stairwell that is packed with piles of objects, mainly books and, of course, some of the plastic things. It would be very difficult to safely navigate such a stairwell. So it's something that we are always concerned about when we see this in a hoarded home. Another concern that was evident from the case that was presented earlier is blocked exits. So in this case, when we have a front door that no one could enter if they needed to, often there is a door somewhere that people can come and go from. Occasionally we encounter a very serious case where it's only windows that are accessible. But this means that medical personnel and other emergency people are unable to enter a home that's hoarded in that way. A further concern is the cost to the community. So it can run into the tens of thousands of dollars to clean up a truly hoarded home. And for a community that with unlimited budget, that's obviously an issue. It's even an issue for family members and for the person with hoarding, because such services are not inexpensive and may be needed in very severe cases where there is a time limit to how long the authorities will permit the person to stay in the home without cleaning it. Homelessness is a particular concern among people who hoard, and we're pleased to know people who've worked hard on this problem and with good intervention can prevent homelessness. But it's certainly a concern as people who are renting homes are unable to keep up the home and are evicted, and then the question is, where can they go? So that's a concern as well. And of course, fire is a deadly concern. This is a home in which the 82-year-old man who lived on that second floor in the bedroom there was unable to get out in time, even though the fire department responded almost immediately to the neighbor's call for help. In this case, it was a hoarded home and the fire department was unable to get in time to prevent that death. As you'll see from the next slide, the Melbourne has conducted some research on fires and the role of hoarded homes in those situations. They collected 10 years of records over time and found that a very small percentage of the fires that they tracked involved hoarding. So this is 0.25%, meaning a very low rate. Less than 1% of the fires were of hoarded homes. But in those hoarded homes, those situations accounted for almost a quarter of the deaths involved in any homes that were fire related for the Melbourne Fire Department. So it gives you a flavor that death is indeed a very serious potential consequence of a seriously hoarded home. Now, work impairment is another major vulnerability here, a problem for people with hoarding. What you see on this slide is that our red bar on the left is the frequency of work impairment among people with hoarding problems. And on the far right, you see that that's getting pretty close to the level of work impairment for someone with a psychotic condition, which can certainly impair functioning very seriously in the work arena. We also see a good bit of problem with family conflict and rejection. So family conflict is actually surprisingly common, and I'm sure many of you in the audience are well aware of this. What we often hear from are spouses or children of people who have a serious hoarding problem, who are very, very concerned about it and often fed up, and in addition to being very worried about the difficulty. We certainly have seen divorces result from this kind of problem, and estrangement among family members because of it. What you see here in the, if we can go back to that for one sec, is that, sorry, there you go. The family members can be quite rejecting of someone with a hoarding problem. So this is a patient rejection scale that is used to measure the degree to which a family member is rejecting, very angry with, and intolerant of their family member who has, in the case on the right, schizophrenia, for example, where there's quite a lot of rejection, certainly in this country. And you see that hoarding, the rate there is equally high, if not higher. So a concern for family members for certain. We have other vulnerabilities and associated features. So we've put together here a list of features of hoarding, which also represent vulnerabilities to the problem. And we don't always know whether or not, a chicken and egg problem. So if we start with the first one, is poor health or disabilities a causal feature in hoarding, or is it a consequence of hoarding? So in many cases, the hoarded home is actually causing problems by itself. For example, someone who is prone to lung disease may well develop COPD in a hoarded home that is not able to be cleaned properly. Other people develop difficulty as they try to walk around or over the piles of clutter and end up with some difficulty there. You can imagine that this is especially prominent among older adults in these situations. Another feature of hoarding that we pretty much all agree on is that people who hoard have difficulty making decisions. Certainly they have difficulty making decisions about their own objects and whether to keep or discard them, whether to acquire or not, who to give gifts to if they've purchased gifts, etc. We don't always know whether the indecisiveness also expands to other areas of their lives, though it may well. Perfectionism is another concern that we see, and we see many examples of this. Some that we can think of are people have difficulty deciding to let go of or discard an object that isn't all together. So a suitcase that's missing its key, or a game box that's missing its top, may be difficult for someone to throw away because somehow it's not all together, and that's a perfectionistic feature. And there are many other forms of perfectionism that we see. What we can say is that perfectionism is certainly not going to be a trait that's going to be helpful in getting over the hoarding. And so we may very well have to work on that directly. Procrastination is another problem. People often tell themselves that they will be able to clear the clutter if only they have a free half day or a free couple of days to work on it. And then that seems never to come around because they do not prioritize that. They often put off other tasks in their lives as well. Attention focus has already been mentioned as a significant problem. Attention deficit disorder is commonly comorbid with hoarding disorder. And it often seems that a person can't see the forest for the trees. So when they look at an object and are trying to make decisions about what to do with it, they get caught up in the overall situation rather than being able to see it for what it is. So in some cases, we'll say that if you pick up a pen or a pencil and are deciding what to do with it, instead of thinking about how many you have and where they should be kept in the study, for example, or in the drawer that holds pencils. Instead, you see it as a special object, and attention goes to the features of the object rather than to its purpose and where it might be kept. There are many other aspects of it. When we start working with people on clearing clutter, we often find that they get distracted because there is so much material in the home that they bounce from object to object. So attention focusing will be an issue in treatment. There are two other features that we've added here, and one of which is emotion regulation. So let me speak for a moment about that. And what we see here are several aspects of emotion regulation that seem to be not uncommon, at least among people with hoarding problems. Anxiety sensitivity is one, in which people who hoard seem to be overly anxious or easily made anxious about various aspects of living their daily lives. And so that seems to be connected to whether they save and cannot discard an object. Distress tolerance is another that is, of course, related to that. That is, individuals seem to have difficulty tolerating distress, anxiety being one example of distress, and therefore coping with it effectively. And that seems to then set off more emotional reactions that make it difficult to make decisions about objects. Negative urgency refers to rash and regrettable acts. When a person is aroused about something, that is, they do something impulsively that then contributes to the problem, or at least prevents them from advancing. Experiential avoidance, we've already mentioned in a number of contexts. That is, people who hoard have a tendency to avoid a variety of situations that make them unhappy or uncomfortable, and that contributes to hoarding in its own way. With regard to other final aspect of vulnerability, let's talk about family again. And here what we want to show is that a large portion of people with hoarding problems have first-degree family members who have had hoarding problems or who have them currently. So here you can see that in the hoarding group, which is in blue there on your slide, that those individuals had parents, more than half had a parent with hoarding disorder, and almost 60% had any first-degree relative, parents, siblings, for example, who had hoarding problems. The OCD group had far less than that, about less than half, and the control sample that we used for this study had much less than that. So clearly, it's far more likely that if someone has a serious hoarding problem, they have family members who have had those problems. You'll notice that 37% of people with hoarding disorder grew up in cluttered homes, not necessarily full hoarding disorder, but certainly cluttered homes, compared to lower rates for other individuals. What we want to be alert to here is that when you're talking with family members of someone that they're reporting has hoarding, it's possible that those family members also have some hoarding problems. So be aware of that in your clinical work or in your discussion with family members. Family burden is also an issue here because growing up in a hoarded home is associated with more embarrassment on the person's part, a less willingness to invite friends over for obvious reasons because the home is so cluttered, more strain in the relationship with one's parents. And so children of people with hoarding problems often have great resentment as they grow into adulthood about this situation. And they've had a less happy childhood as a result of this. Now, let's move on and talk a little bit about a model for understanding hoarding, which hopefully will make sense in the context that we've already described. We've just described on the left-hand side some of the vulnerabilities that may make people more prone to hoarding disorder. And here we also want to talk about the features of hoarding in the middle and how those come about. So let's go next to information processing problems. And we'll see here that they are multiple, some of which we've mentioned. Attention, we already know that that could contribute to hoarding problems. Categorization, people have difficulty deciding what category an object belongs in, and therefore where to put it, how to keep it, what to do with it. They struggle with memory. And in many cases, we've heard people who hoard just say to us that they're concerned that they don't have a good memory. And in fact, the data don't show that they have poor memories, but rather that they're more anxious about whether they will remember something that they think might be important. Perception is another area. And here there's almost a set of positive features, if you will, where people are especially attuned to the texture, the color, the feel of something, the way it looks, the way it smells, etc. Their sensory perception can be quite acute. And along with that, their ability to associate the object with a variety of other contexts. So their thinking becomes complex in this process as they think about the many things they could do with a particular object or ways of making use of it in some other fashion besides the fashion, whatever it was intended for. This leads people to save all kinds of things like used toilet paper rolls, for example, because who knows, one day that might be useful in some project or another. These types of information processing deficits lead to difficulties in making decisions because basically the brain is churning away with a great deal of detail that is more than most people can cope with. No surprise. Now, if we look at emotional attachments, we see that there are four main areas. These are beliefs people hold about their objects and the emotions that drive those beliefs and result from it. So identity, let me go back a sec. So we're identity and opportunity, there we go. So a person's identity and the opportunity, objects present many features for that. And this is motivated by concerns about loss, concerns about safety and comfort with regard to objects is motivated by the level of distress a person has. Guilt generates a lot of concern about responsibility and waste. And pleasure is taken in many objects which represent beauty and aesthetics to the person. So these are four basic sets of beliefs and emotion-related aspects of hoarding. And they contribute greatly to the symptoms. And then if we look at the emotions specifically, what we see in hoarding is that we have both positive emotions and negative ones. To be clear, the negative ones predominate. They are the primary drivers of hoarding behavior. But positive emotions also have an impact on whether a person will acquire an item, because acquiring generates a lot of positivity for them. And also when they find things in the pile, you'll often see these fondness, joy, relief in finding something, and so forth. So hoarding is a little different from other problems in that it has both positive features and negative features in the emotional state that drive it. And then these lead to reinforcement patterns. So what we see is that positive emotions generate a great deal of positive reinforcement of hoarding behavior. The negative emotions lead people to avoid getting rid of objects or avoid not acquiring something for fear they'll make a mistake. And then that also adds to it. If these reinforcement patterns do not leave the person with opportunities to test their beliefs and appraisals as they continue the hoarding behavior and don't give themselves an opportunity to behave differently and see what effect that has. And so they don't develop alternative beliefs. And our job in treatment is to modify this pattern right here in order to improve the hoarding situation. So let's go on to talk about insight a bit before we talk about treatment. And first, to understand what is absent insight. So insight, as we know, and has been pointed out previously, is about awareness of the illness, awareness that there is a problem. Some things that contribute to low insight are clutter blindness. After you've lived in a home with many hoarded objects and a lot of clutter, people tend to be blind to the clutter. They don't notice it, and they're startled when they see a photograph of their own home to see just exactly what it does look like to an outsider. They're often afraid of being discovered and so want to avoid letting anyone know, and certainly not wanting to confess to a hoarding problem. They may feel hopelessness, which can result from their defensiveness and resentment, especially if they've ever been investigated by the authorities. They're going to want to deny that they have a problem. And certainly they feel the shame, and they're often feel that they're unable to cope with it, that the clutter is so overwhelming, they can't continue. And so their coping is not adequate to the task. And they develop overvalued beliefs about the importance of their possessions in an effort to hang on to them, and the cycle continues. The social context in which people live also affects how much insight they have. So we know that the TV affects, and the TV language. Be very careful about language that you use with people who hoard. So we try not to talk about their junk. Randy and I have used the term stuff to describe objects that they have. We try to take our cue from the person who is hoarding. What do they call their own things? And we try to adopt that language. Family members also can be problematic in terms of language that they use in their accusatory effort. So a lot of insight in a person who's hoarding depends on who's asking the questions. With regard to motivation to change, which is something that's important for his first step in treatment, is that the benefits of change have to outweigh the person's sense of the cost of change. And this is a problem that we then have to deal with in our efforts to guide people into treatment. So what makes a person motivated to change? The importance of the effort, that is, what do they have to gain by improving the look and the feel of the home, by reducing the amount of clutter, by being able to find things that are lost in the piles, by being able to invite people over. And how much confidence do they have that they could change if they wanted? People who hoard are almost always ambivalent about whether they really do want to get rid of their stuff, because they are very, very attached to it. So we have to focus on that ambivalence. And we discover that even people with very poor insight are at least ambivalent. They have some sense that other people know that the way they live is not a good one, and they feel ashamed. So they don't invite people into their home. So they know what their home ought to look like from their own perspective, but denial is so easy when it's such a hard problem. So our job as clinicians or community members or family members is to appreciate the other side of their ambivalence and to begin there in order to help them approach change. So that means listening very carefully to what people tell you about the meaning of their possessions, using the language that they describe, asking questions about their objects, and so forth. We must be interested. And then suspending our own frame of reference about what a house should look like. We are not aiming for house beautiful here. We are aiming for livable homes. And what that looks like is very different across different home settings. So we must be careful about our own assumptions about that. We also want to help people celebrate their possessions, not focusing so much on discarding, but what has been the value of this object to them, And what does it mean in the context of their lives? We try to focus particularly on safety and function. And whenever we talk to family members, we want to make sure that they understand that the goal here is that the family member with a hoarding problem must be safe. And we want to promote their ability to function effectively in the ways that they value in their own lives. So we start our journey with clients by looking at the hoarding and the saving of possessions as a strength and how we can help them achieve what it is they were trying for. So if we don't start there by sitting on the same side of the table as the person with hoarding and looking at the clutter problem, then the client's experience is that they might want to get rid of the clutter, but the therapist just wants them to get rid of their stuff. And whenever that happens and you feel the push against you as a clinician or as a community member, and you find yourself arguing for change, the person who hoards is going to have to argue against it. So be very, very careful about how you set up that experience for people. It's a very important part of the intervention process. So let me describe that briefly now. Cognitive behavior therapy for hoarding has several elements. The first of which is to understand the severity of the problem and the nature of the problem. So we do a thorough assessment using a variety of instruments to help us understand it. We ask a lot of questions, and we formulate an understanding with the client of how it works for them. What are the driving emotions? What are the driving beliefs? How do they respond behaviorally in various situations? So that we bring them along with us. We also look at their motivation for change and think about the strategies that might enhance that motivation. And there are many of them. And we hope that during the course of the conference, you gain some knowledge of these. We also work hard on skills. Organizational skills are critical for helping people figure out where to put things, how much of anything they have so that they can decide how much they need. We also work on problem-solving skills because it's often a challenge to figure out when you see a very cluttered room where you're going to start and how you're going to move forward with it. And in any given situation about a decision to discard, what to do with an object. We want to help people change their attachment to the objects that they have. And that means working on the beliefs that they have and the emotions. And we do that through direct practice, and we also do it through some cognitive therapy strategies. And then to change the patterns of acquiring that they have. And this is often a good place to start the treatment, because if a great deal of objects, many objects are coming into the home, we want to stem that tide before we get going, trying to figure out what to do with the ones that are already in the home. Now, let me show you the outcomes of those treatments. This is a very brief a study we did about 10 years ago. And here you see that in yellow, the waitlisted people who got no treatment for 12 weeks didn't change hardly at all, only maybe 3% in terms of reduction of symptoms. Whereas those who got the cognitive behavioral treatment began to approach 17, 18% change or reduction in the hoarding symptoms. And as they continued from 12 weeks to 26 sessions, then they got even better, down around the 30% improvement rate. That's still a low improvement rate compared to some other mental health problems that we do cognitive behavior therapy for. So we do have a ways to go. The next slide shows treatment response rate and self-rating. So these are people with hoarding rating themselves. And you see that right after treatment, at post-treatment in the blue bars, we have about 75% who rated themselves as much or very much improved. And clinicians, about 65% of them rated the person much or very much improved. And then at follow-up, we lost very few gains overall, somewhere around 70% among self-rated and above 55% for clinician rated. So that's the treatment outcome data. We know we need to improve it. We do know that some factors have predicted successful treatments, and so we want to pay attention to these. Doing the homework, no surprise, is a very important part of the process. Home visits by clinicians and others is especially important because people work hard to keep their home in better shape when someone is coming into it on a regular basis. Perfectionism is problematic for people, so we will want to help them with that perfectionism in order to improve our outcomes. And we want to help them change their emotional attachment to the objects, because changing that really makes a difference in the overall ability to clear clutter. We know that we need to adapt the treatment for older adults, probably with less cognitive therapy and more practical strategies for managing time and setting goals. And we also need to adapt it for children because there's very little research done in this area at this time. So in summary, we know that hoarding disorder is an accepted psychiatric diagnosis and that its features represent vulnerabilities to the problem. So we have a variety of features and vulnerabilities that we need to attend to as we enter the treatment process. Hoarding develops from those, from information processing problems, from beliefs about possessions and attachments to those possessions, and from both the positive and the negative emotions that are evident. Cognitive behavior therapy methods that are specialized for hoarding disorder are effective for adults. And we need some modifications for older adults, and we need to improve the treatment overall. So we thank you for your attention to the talk, and we're happy to take your questions at this point.
Yes, thank you. We look forward to answering your questions.